Dr. Carl Fisher. Welcome to the Science of Psychotherapy podcast. So great to have you on the show.
It's great to be here. Thanks so much for having me and for inviting me in to talk to your community.
It's a pleasure. Richard here. So we're both here going to grill you and find out all this really interesting stuff. We always find it fascinating. People connect with us and we communicate and then find I said to you before, a treasure trove of really interesting and fascinating stuff. But your work is a lot to do in the area of addiction, but you, as we said, you're an associate professor at Columbia, and looking at your papers, there's a lot of diversity in the approach you do. But this area is what's important. So, can you give us a bit of a background, a bit of a fill-in about where you came from and how this became your fascination or your interest and your work?
Well, it's unavoidable, in my view, to look at addiction across the clinical perspective, and I wasn't immediately focused on it when I started my medical school training and my work in psychiatry, but I just kept on coming back and back against problems with not just substance use disorders, but people struggling with other addictive behaviors and just the feeling of being out of control. And it led me back to something that was really important in my own early life. Both of my parents were alcoholics, and I started to notice that I was avoiding that a little bit in my practice, but it wasn't avoidable. And it was really incumbent on me in the type of work I was doing, especially when later I went into the prison system or just started working in more of a public psychiatry setting, to learn more about the way people struggle with really out of control behaviors, all the way down to more nuanced sort of everyday addictions with work and sex and money and all the rest. And it's been a wonderful journey to start to learn some of those concrete skills, because I think they really they translate to the other work, because as I've narrowed into addiction as a sort of extreme phenomenon, the further I go, the more I see commonalities with the rest of human experience, and a lot of problems that I didn't even consider were addictions beforehand.
Now, before we drill down into what you've learned, how you've learned this along the way, has it been just through your clinical practice, or did you do any specific coursework? How have you been learning?
Yeah, it's such a great question. I mean, what I found for myself in my clinical practice is that became a job to think about what are my skills and how am I doing justice by my patients and by my clinical practice, to consider that as a sort of domain of self-development and practice development, and not necessarily just draw on my own personal experiences or what I learned 5 or 10 years ago. But that being said, that's my little disclaimer, because I did start with a personal commitment to meditation and mindfulness practice before I even went to medical school. Early on, I had the good luck to do a fellowship in Seoul, South Korea, and essentially stumbled into their version of Zen meditation practice, which in Korean is called Son. And it was just revolutionary for me personally to start studying in that world. And then later, when I came into medicine, this was when I started getting towards psychiatry and neuroscience. It was like 2005, 2006. And we were really seeing the beginnings of an explosion of mindfulness related work and manualized treatments for mindfulness. Of course, mindfulness-based stress reduction goes back decades, but I think really the past decade or two has been the true explosion in really rigorous and science-based and empirically studied interventions and skills across a whole spectrum of mental health interventions. And so seeking out mentors, certainly when I went to psychiatry residency at Columbia University, that we didn't have a mindfulness track. It wasn't like we had a whole multi-session course. It was still a little young for that, but plenty of supervisors and colleagues who were interested in going to folks for mentorship, and then just seeking out the wealth of trainings and practices that people offer. Still sort of early days, but there are wonderful conferences There's a Buddhist recovery network that is for both clinicians and the lay public about working with addictions around not just mindfulness as a specific skill, but the sort of broader repertoire of what you might call Buddhist infused psychology and psychotherapy. The Mind and Life Research Institute, which is the institute that's famous for bringing the Dalai Lama into conversation with the Western science. They have some regular conferences that I've had the great honor to attend. So it's exploding. There's a lot out there nowadays.
Yeah. Can I take you back to your Korean experience? I have to admit I don't know anything about the meditation coming out of Korea. How did that happen, and what was that experience for you?
I was just interested. I was a book Buddhist, which is a slightly derogatory term that people use sometimes. So I try to shy away from it. But because I think whatever path you get exposed to, whatever is useful is fine.
Yeah.
But for me, I was just reading books on my own. And I thought I must have read in some chapter somewhere that it was good to sit with other people. And I went to a temple, and I was very Orientalist about it. I was coming from New Jersey, and I thought, oh, this is going to be so mystical. And I had these visions of a sort of David Carradine kind of like old master who would teach me. And I found a guy from New Jersey, from probably half an hour away from where I grew up. But a man who seriously devoted himself to Zen practice ages ago and was now running an international Zen center in Korea. He's not there anymore, but got the opportunity not just to sit and work on the sort of specific set of meditation related skills, but also integrating it into a sort of ongoing practice of living and how you take it out into the rest of the world. And it was just lovely. It was really
wow. Yeah. And having no idea, I guess, that this is a framework that is going to carry you through a future clinical practice.
No idea. No, at that point I thought I wanted to be a surgeon, so I didn't even want to talk to people that much.
Yeah. I mean, it's always this fascinating thing that we come to, and in the West we have this habit of discovering something new. But of course, mindfulness, and particularly, as you say, with meditation. I mean, this is millennia we're talking about in the Buddhist. A dear friend of mine in Singapore, Jeffrey Poe, and he wrote a number of books on Buddhist psychology. And we were talking to him about it, and he said the trouble of it is I am a Buddhist, and I've always been one. My father was one, my grandfather was one, my great-grandfather was one, so I can go back. And so this is interesting, the way of translating it into the idea of discovering. But then things need to be changed. And this is the wonders of the Dalai Lama. And of course, as you bring him in, that he was a great advocate of advancing and shifting and changing and adjusting. So you're really, to some degree, have you felt a part of this sort of integration of the history into the current thing? How's that been for you?
It's such an important question, and it's such an important debate. Actually, it's quite rich right now. About the one way that you could frame the question that's coming to my mind is, to what extent can we take meditation and other types of mindfulness practices, abstract them, and insert them into a Western medical context, versus how much are they culture and values bound, and is it even potentially harmful to try to extract some sort of supposedly secular training from a wisdom tradition? And I think to give an answer definitively on one or the other side would be too misleading. It's such a complex topic, but by the same token, it would be misleading to say absolutely we can just kind of grab what we need or grab what we think might be useful, because mindfulness was not developed as some sort of brain hack. It was developed as part of a deep investigation into suffering and the nature of suffering, and came up through a religious tradition. Especially people who are allergic to the notion of religion in the West like to say that Buddhism is not really a religion, or it's a science-compatible religion. It's a religion because it has a shared culture of values and ethical teachings and ontological and epistemological claims about the world. And we can't divorce that. for a practicing clinician, for myself, I think it returns back to the question of what is appropriate and helpful to introduce into the clinical encounter. And I think there is a role for introducing one piece of, say, a mental training skill, but it might lead to some of those deeper questions, in which case it really is necessary to be diligent about respecting the patient's values and views, and not trying to act as a sort of stealth missionary or a sort of proselytizer, because that's definitely not part of the Buddhist tradition.
Yeah.
Very true.
So let's dive into addiction, and specifically, your approach and your experiences with working with addiction, and what you've learned.
Yeah, well, in terms of my approach, I guess that just makes me think of what happens when a person walks in the room, or increasingly nowadays, if somebody logs onto a Zoom call and I'm faced with a question, what are you looking to change, or how can I help you? And I think of myself as a harm reduction oriented clinician, which just means to me that I meet the person where they are, and I start with what their priorities are. So you can imagine two people with identical addiction severities in terms of problems at work, or problems in their home, or their life falling apart. And one might say, I really need help becoming abstinent. And the other might say, I just want to feel better. And I don't think we're doing anyone any favors by treating those two people in the same way. Unfortunately, that is the way we often treat people across that severity level, especially if it's involved with the court or some other sort of broader system. But the real question has to start with what is your suffering, and what is the thing that you don't have control over, and what are you looking to change? And it varies quite a bit.
Yeah, I know. I mean, you do have a book coming out next year called The Urge, which is a history of addiction. But there's a great quote that I noticed in a couple of the comments, and we have heard a lot about addiction as a breakdown of connection and engagement. But here the quote is the terrifying breakdown of reason. And so this is it's slightly different from this sort of right brain type of attachment things to this sort of left brain. Can you expand a little bit on that, or how that interrelates?
Absolutely. So reason is not the sum total, and if anything, we're often too focused on reason in the Western tradition. However, when trying to boil down addiction to its essence, I think that one of the truly unifying characteristics is the sense of being out of control. Is a sense of feeling like one's actions and behaviors don't line up with one's previously held intentions. And that goes back all the way to ancient Greek philosophy and to other philosophical traditions. In the Socratic dialogues that Plato recorded, and in Aristotle, they called it akrasia, which was sometimes translated as incontinence, which I think is a sort of funny word to apply to it. But it refers to the sense of not being able to hold that intention, or not being able to carry through with it. And that's often when somebody has severe addiction, that's usually how they come into the office. They say, I really feel like I want to stop drinking or using. And I've written it down in my journal, and I've made the promise to my partner, and I've tried to throw out all the bottles, and still somehow, mystifyingly, I find myself back where I started. Why does that happen? And how do I get help with that? And that's the breakdown of reason that I'm thinking of, that it seems as if they've made that rational and clear commitment, and yet cannot hold to it. And how that happens and why that happens, that can be extremely varied and diverse. It often gets back to that point that you mentioned about a breakdown in connection, or alienation, or dislocation, or a lack of meaning and purpose in one's life because of structural factors, certainly everywhere, but especially in the United States, racism and systems of oppression, and other sorts of economic or sociological problems people might have. So the fact that it sort of triangulates on this experience of reason and irrationality certainly doesn't preclude any of those other
Yeah.
factors from being important.
Yeah, Dr. Oliver Morgan, who we've talked to a number of times and has become a good friend, he talks about addiction as an attachment disorder. How have you found, does that sit with you?
I think it's often an attachment disorder. I think for any theory or any summation that somebody has, any grand sort of unified explanation for addiction, there's always the exception that proves the rule.
Yep,
So
of course.
there's certainly people who might have grown up in a lovely setting and had great early childhood attachment experiences and seem to have no predisposing psychological or biological issue, and yet they still somehow develop an addiction. So I wouldn't generalize, but I think that's the perspective, the notion of addiction as an attachment disorder, that's increasingly lost, especially from mainstream medicine. And by medicine, I mean physicians and people who deal in medications and folks who set policy often. That the issue of relationship is so crucial to addiction. It's relationship to others, relationship to behaviors, relationship to the internal parts of oneself, or relationship to urges and expectations and one's own experience of suffering. And that's an important corrective against the notion that addiction is just a disease that's been visited upon us by biology, that a drug is the thing that causes the addiction. Because what that does is it just eliminates any individual's experience of choice or agency or self-authoring, which is often so crucial, not just in the understanding, but the treatment.
Yeah,
and that sense that it's a drug that takes you out of it too. So that medication-based thing, and you actually make a big point of trying and utilizing other methods. We've already talked about sort of mindfulness and meditation, but you also talk about yoga. What are some of these approaches? Is it an individually based decision that you make about the sorts of things you bring in and when you bring in, but you have a wide range of offerings that you give your clients?
Absolutely. It's often individual. I will say it's not just happenstance that many of the formal psychotherapeutic and medical interventions come as part of a group treatment. And so even though it's highly individualized, people get a great deal of strength and support from learning these practices in a group. Specifically for addiction, there's one called MORE. There's another quite good one called Mindfulness-Based Relapse Prevention, which is many of these things are taught in a group context precisely because it can be hard to sit with one's urges and experiences and emotions. And that relates especially to the sort of stereotypical view of mindfulness practice of just sitting meditation. But whether or not somebody is in a group, it's important to find other little entry points. I had a supervisor who said once, it's like trying to land a helicopter in a swamp. You just need that one patch of dry land. And I think about that all the time, because for one person, they might not be able to sit with their negative feelings and urges and intrusive anxiety. And so you need to find some sort of daily informal practice. And there's actually some recent research that suggests that it's the informal practice outside of the sitting meditation that's more important for the benefits, especially in an addiction context. So whether that means finding a spot in someone's daily routine that's consistent and making that a dedicated mindful walking path. Back when people used to commute more, we would say, you've got a 10-minute walk from the subway to your apartment. Let's make sure that that's always mindful. No offense, guys, but no podcasts, no music, no nothing. Just take a 10-minute pause. At other points, it might be a kitchen practice. I've seen multiple people. The kitchen is really important to not just be quiet with it, but to stay with every activity, to open and close every cabinet with full awareness and watch it all the way through. And that can be a very powerful form of practice that translates to when somebody is waking up at 2 a.m. beset by urges and cravings and thinking, I can't sleep, I just need one more drink, whatever. It's all part of the same mix.
Okay, so that's very much making sure that you're engaging your prefrontal cortex in the moment, with that sort of acutely being aware of everything that's happening around you. That's the sort of mindfulness you're talking about.
That's important. I think, the prefrontal cortex and its relationship to other brain areas, I think is really rapidly developing, and an important set of scientific hypotheses that need more exploration. I think in a certain way, the first generation of neuroscientific investigation into addiction relied a little too much on this sort of combative model of the sort of logical prefrontal cortex trying to suppress or control the bad negative urges, and that in a certain way is too simplistic. And I don't think that's what you're trying to say, by the way. I just bring it up because I think that's a common sort of lay general understanding of what the prefrontal cortex does. It has an intuitive appeal. Like, only if I could strengthen my control, I could just take this negative part of myself and squish it down into its little domain, and then I would be able to do what I need to do. But there's a lot of work right now, and Judd Brewer at Brown is doing a fair bit of this work about the posterior cingulate cortex, which is a part of the brain that's commonly associated with the self, and specifically self-referential ideas about what you need or what I want, and craving, and those types of feelings, like cravings, are associated with increased activity in the posterior cingulate cortex. And there are certain contemplative and meditative interventions that appear to lower the activity in that brain area, which to me suggests that what we need to do is not so much like ramp up our control, but actually take a step back to let go, and to let go of that sense of self-referential processing, and to relax in a way.
Right. It's interesting because that as you go down the midline, you're talking about default mode network, that sort of aspect, but then also that posterior cingulate is relevant in the context of the salience network, and so all these things. Now, because you came in with a bit of energy, but whether, I don't know whether you were noticed before or after, but certainly the one that seems to be noticed is a Nautilus article in about 2007 or 8 or something, where you were talking against willpower. It was, and that got a lot of notice at the time. Was it really so difficult to convince people, or were they? Has this changed rapidly? This shift in perception that you're talking about?
Absolutely. It's hard to convince other people. It's hard to convince myself that willpower is not as important as we assume. I was interviewed on a radio show there, and I don't know if this was a gotcha moment or just neither me nor the interviewer realized, but he said, "What do you struggle with regarding willpower?" And I said, "Oh, I eat too much ice cream." The whole point of the piece was that willpower is too general and a harmful and misleading concept, because we treat it like a wastebasket. We roll up a bunch of more specific and more useful cognitive and emotional tasks into this one monolithic idea of willpower. And I think that's a really important clinical intervention sometimes, just to tell someone. My red flag always goes up when someone says will or willpower, to say, what do you mean by that? Let's talk about what you mean by willpower, because for one person, it just means I had a craving in the moment and I couldn't stop myself from doing it. In the other, it means that my intentions shifted. And on Tuesday morning, I thought that I would be on a diet, and Tuesday afternoon, I had a piece of pie. And those are two very different cognitive experiences.
Yeah. Can we just shift now? I've got a burning question, and that's about pharmaceutical intervention and where you stand about your drug intervention. Where does that sit in your practice around addiction?
Well, for addiction specifically, we're in a funny situation where pharmaceuticals are rarely the whole story, but they're also simultaneously vastly underutilized. And I think we've lost the middle ground in between. We've lost that sort of common sense middle ground where medications for substance use disorders are often necessary and life-saving, but they're not sufficient. Because it's so ideologically charged, people find themselves polarized into camps, where one camp says it's not real sobriety or it's not real recovery and it's better to be off of medications. And the other camp often advocating for policy changes that increase access to these life-saving medications, say, or at least imply that it's the only thing necessary, that if only we had enough Suboxone or buprenorphine, or if only we had enough methadone, then our addiction problem would go away. And that's a problem that stretches back decades, especially in the US. There's a professor at Columbia, Gerald Clerman, who had this great dichotomy between pharmacological Calvinism versus psychotropic hedonism. And
Right.
the notion is that we either act as if suffering is somehow virtuous and we should avoid anything that would help, or we say, forget it, let's do anything, let's just be hedonists and use whatever takes away our suffering or appears to take away our suffering. So to get back to your question, psychopharmaceuticals are often really important and crucial, especially in opioid use disorder.
Mm-hmm.
It's really the only intervention that has been shown to reduce death. So it's really important to stabilize people and get them onto often Suboxone, but also other interventions like long-acting naltrexone, just so that they can show up and get to the next appointment and lose that sense of just overwhelming fear that's attached to the overdose process. There's also important roles for medications for alcohol use disorder as well, also terribly underutilized. But just like a lot of the rest of the recovery process, that's often the first step. That's like signing up for the marathon.
Mm-hmm.
And then, okay, good, do it. And then you have to run the marathon.
Yeah. We talk about this this a lot in what I describe it in some of my stuff as creating a therapeutic consciousness, or creating a state where therapy is viable. And I heard someone put it nicely when they dealt with a lot of homeless people in relation to addiction and various things. And he said, you've got a homeless person coming in there for addiction. There's no point buying them a sofa until you found them somewhere to live. So getting them into that sense of balance and some positive state of homeostasis, as different from this dysfunctional sort of state that you describe occurs when they've got those urges and addictions and fears and all those things. That's not a great place to start from.
Yeah, good point. Yeah, I mean, there's many psychopathologies that do need that sort of intervention at the outset, just to bring the person into the possibility of psychological intervention. So,
and the use of psychopharmacology is often a good laboratory and a good reflection of other thoughts about the self and thoughts about recovery. So there's often so much shame and guilt attached to the use of medications. And it's important to investigate. If somebody really has a lot of negative feelings about themselves, as if I should be able to deal with this without medications, or what does it say about me that I am still on this medication? That's not a blank check to just continue medications indefinitely, but it's often very rich to go deeper and look at what sort of attitude that reveals about health and wellness, about what it means to be dependent, or what it means to take care of oneself. And that's why I'm glad to be able to do that, to work in both psychotherapy and with medications. But I think that's something that folks who do not prescribe medications can really readily explore, and is often really crucial to one of the key tasks in somebody dealing with addiction is what is my recovery? What does recovery mean to me? What is my version of a good life? What is my version of flourishing? What am I working toward? Because if somebody's goal is, I've been on Suboxone for 2 years, I want to get off Suboxone because I think that means that I'd be a somehow better version of myself. That's fine. But then the necessary next step is, well, what needs to be in place for that? And when you got off that medication, even if you did have some sort of discontinuation struggles with it, what would be there that would be better than today? And how can we work toward it?
Yeah, and have you built the scaffolding, to remove the drug? Can I ask also, what's the most challenging type of addiction that you deal with?
Oh, that's tricky. I would hesitate. The advocates and the members of different recovery communities would really be upset with me if I said for various reasons.
Set
Both
up.
because
We got him.
I'd be implying that they were somehow sicker, but also I think there's a lot of like pride associated with beating the tough ones. I could say opioid use disorder because that has such a high rate of overdose and death, and that of course is more and more high stakes as fentanyl and other sorts of poisons essentially get into the drug supply. But I could also say eating, because people who have what they themselves consider to be an addictive relationship to food, they can't choose abstinence. They have to live in that messy middle ground between choice and compulsion and navigate their relationship. And that can be a very, very challenging and sometimes life-threatening. If you look at, say, World Health Organization statistics, heart disease and cardiovascular diseases and even cancers related to those so-called lifestyle illnesses are extremely high. So it can kill you tomorrow.
And that issue with sugar and salt, both of them doing these disastrous things, and the best, one of the best healing mechanisms that we've seen, and we've examined this in some of the lifestyle stuff of where heart problems have dropped by 60-70% and diabetes by 40 and 50%, is when there's been a huge economic crisis, and Cuba has got a lot of statistics about that, and it's quite fascinating. Not that we want to actually do that to make people well, but it is quite fascinating how that affects the lack of access to luxury, I suppose, is one of the things.
Yeah, and like we've just been observing recently with this virus, obesity and the ability to tackle a virus is greatly diminished. So, big problem all around.
Absolutely, yeah. The sort of knock-on chain of causation that it causes, and even at a more subtle level, obesity leads to problems with mobility, leads with problems getting out of the house, problems connecting with other people, problems engaging with meaningful life activities, can be a real impediment to health and flourishing. And obesity, you mentioned obesity. I think there was a proposal in the American Journal of Psychiatry that obesity be regarded as a mental disorder by the head of the National Institute of Drug Abuse, Nora Volkow. And I think that's an important and provocative line of questioning to explore. And we have to be careful about just associating obesity with an addictive relationship to food, because there are people who have what we would call in the standard DSM-5 nomenclature, a binge eating disorder, and they appear normal weight. And there are people who might be obese who don't necessarily have any sort of disordered relationship with food, necessarily, getting back to this question of relationship and attachment. And so that's a place that is sometimes an addictive sort of process can be hiding in plain sight, is when somebody is struggling with their eating and it doesn't even necessarily manifest in that way. I've had that experience in my own clinical practice where whether or not somebody is in recovery from a more severe substance use disorder, we peel back the layers of the onion a little bit, and then we discover that I feel out of control when it relates to X and Y and Z, money, sex, relationships, whatever.
And it manifests elsewhere. Just want to jump in that we're talking about body movement, activity. We talked about meditation and mindfulness. I just, one of the things, it's not really a clean segue, but I'm trying to make it so. But into this area of yoga is one of the things that you just specifically mentioned, and that will jump into people's minds because Bessel van der Kolk has been talking about yoga as an important process in dealing with trauma and complex trauma recoveries. So this type, is it specifically yoga's activity? Just some of those frameworks of what that practice brings out for people as you're working with them in addictions.
Yeah, yoga, I think, can be really powerful and helpful and it can occur on multiple levels. So in the same way that someone could come to mindfulness from, say, just an app, or they could come to it from a very deep and considered involvement with the wisdom tradition, in the same way people can come to yoga through a variety of different paths, and they're all valid and they're all great starting points. So at the most straightforward level, somebody could go to any random community yoga class or a gym and have the experience of having to put their phone away, in itself often a major victory, and then be quiet by themselves, staying even among other people with one's own body and with one's own mind, and have the experience of feeling their body on a mat in a safe space. And that can be really wonderful. And the thing that's often missed in contemporary yoga practice is that it was a deep and really varied approach to different forms of mental training, where in asana practice, the physical postures is only one of the limbs. And there are many other limbs. Another one that I think, especially because of the coronavirus, is getting more attention is breathwork. And breathwork has very deep roots. I think you could argue that we wouldn't have any breathwork today if it weren't specifically for yoga-inspired forms of breathwork. And that can be so powerful for folks, just to get a sense of, A, simply just being able to be aware of their breath, but B, being able to make changes in their breath and immediately induce a change in their autonomic nervous system, in their level of stress reactivity, in various directions, not just stress reduction, but also focus and concentration. It gives people such a powerful suite of tools that can help them between sessions.
Yeah, absolutely. You mentioned there about putting your phone away. Have you encountered much in the way of addiction to technology?
Yeah, absolutely. There can be, I think it's useful to think about addiction to technology in a very granular way, because people use those terms interchangeably sometimes: internet addiction or cell phone addiction or smartphone addiction. And that's not really what the relationship is to. It's not to the internet as some sort of abstract network floating above our heads. Some people have an addictive relationship to a specific game or a specific type of interaction. And back when some of the scientific literature was getting up and going, World of Warcraft was a really important one. And we've seen that shift so many different times. In the States, the National Basketball Association, I think, banned Fortnite for a time because their players were staying up late before games. And that's a consideration. And video game addiction is an entirely different set of considerations from, say, for example, pornography addiction, or when people feel like they have out of control sexually related behaviors. Even pornography is probably too narrow of a term, because for some people, it's less about experiencing some sort of sexually titillating material, and it's more about, say, a search, or it's more about, say, the process of engaging with the online forums. And in that way, it's more like gambling. People describe sort of being in the action is a common gambling term, when people feel caught up in the chase, in the pursuit. And you can easily imagine how the internet lends itself to that when people are looking for a specific type of content or issues like that.
Yeah, I have to say, in couples therapy, the thing that seems to come up the most in my experience is an addiction to social media. That you just cannot disconnect from Facebook or Twitter or whatever it might be. Yeah,
that's a big one. Yeah, and I would put in the same category, possibly, at least just the image that brings to mind of, say, like a husband and wife, or it could be a husband and husband, whatever, at a pool party, and one can't put down the phone and the other is getting ignored. And there starts to be issues of disrespect and ideas about the relationship and how a spouse should be to another. And a crucial question in all sorts of addictive behaviors is, what is that doing for you? What is this behavior looking to satisfy? And in social media, for example, you can imagine somebody who's looking to soothe the pain. They're just looking for a distraction from an experience they feel is intolerable, or they could be looking to construct a different self because they feel like their current self is not acceptable in some way, or it could be looking for love and connection, not necessarily the sexual kind, but some sort of I hesitate to say this word because it sounds a little judgmental, but counterfeit connection. in the absence of some sort of meaningful connection in one's daily life, looking for something to sort of somewhat scratch the same itch through TikTok or Instagram or what have you.
Sure. Yeah.
Yeah, there's so many areas and levels and individual contexts, and it's been an extraordinary thing. We're kind of arriving at our time a bit now. We've learned that people can be addicted to a podcast for only so long. But we've covered an extraordinarily fascinating and very clinically relevant, and I know that was one of your intentions, and I think you achieved it beautifully. Sort of talk on this very important subject, and then we've also delved into some areas that I thought were really interesting and surprising. So, and I was sitting back having a good listen. So I hope everyone's enjoyed the same. But have we missed something, or is there something that you'd like to sort of wrap up the session we've had now?
I'll just mention briefly in passing, because I can imagine that your listeners run the whole gamut of different therapeutic practices, that working with people, even with severe addictions, is some of the most satisfying and rewarding and positive experiences I've had as a clinician. It can be frightening sometimes, but the actual rate of recovery is very high. By some estimates, the rate of recovery from severe substance use disorder is actually more positive than from other formal mental disorders, if you follow it out over time. So just simply being there to support someone in their journey as they try to make positive changes is really a lovely thing to do, and can be very satisfying despite the ups and downs. I'm glad to have that opportunity, and it really took some time and some experience and seeing the many different paths that people find to their own personal definition of recovery. But that's not high level theoretical learning. That's really just the humanistic learning, just being there in the trenches with people and trying to show up with empathy and attention and care.
Beautiful. Well, Dr. Carl Erik Fisher, thank you so much for dropping into the Science of Psychotherapy podcast. It was great to get to know you.
It was wonderful. Thank you so much for inviting me on, and for the work that you do. I love the podcast, and I love the sort of deep dive and your warm and empathetic nature. So I really appreciate it. Thanks for having me on.
Thanks. That's lovely.
Okay.
Well, we'll see everybody next time.
Okay. Bye for now.
Bye.